I'm Anthony Leeds, and I'm joined today by Dr. Adrian Brown, who is a Senior Research Fellow at University College London. And he has undertaken work recently on individuals who have developed diabetes some years ago and who are insulin treated. In previous programs in this series, you've heard people like Professor Mike Lean and Shahad Tahiri talk about the experimental work that they have, which shows that reducing weight sufficiently can put a proportion of people into diabetes remission. And these people all had a diagnosis of diabetes for only up to 6 years. However, there are a lot of individuals who were diagnosed many years ago and have now moved on from oral medications to insulin treatment. And those individuals will be asking themselves, well, surely is there a question about weight loss for them as well? So Adrian's going to talk about that this afternoon. Adrian, thank you very much for joining us. Would you like to begin by telling us the issues relating to the study that you undertook a few years ago?
Yes, of course, Tony, and thank you so much for inviting me to give this talk, to have a chat today about this really important topic. So obviously, first of all, why is it important that we look at people living with type 2 diabetes treated on insulin? Now, as you rightly said, a lot of the programs that are currently set up within countries really focus on two things. They focus on preventing diabetes and they focus on remission. Now, obviously, they are really important topics and parts of diabetes, and they've got huge potentials, cost savings. Not despite their sort of limited medical burden and complications compared to people on insulin. Now, what is missing is that we forget about this group of people that we often see in clinical practice that are treated with insulin. Now, type 2 diabetes and people treated on insulin is now routine care, and it still remains the most effective treatment for reducing down blood glucose. So if we look at data, and we look at some UK data from the UK PDS, by the time people are diagnosed with diabetes, what we know is about 50% of the organ that is actually producing insulin actually isn't producing insulin anymore. And what we know is that by 10 years after diagnosis, around 50% of people actually require to be on insulin. Often a thing that isn't discussed when actually people go in and actually are diagnosed with their clinician. Now, despite insulin often being this last resort, often when we go to general practitioners or primary care people, what we often find is that people tend to delay the initiation of insulin. And when we look at average blood glucose, by the time people are actually initiated, it's actually poorly controlled and anywhere between 9.5 to 9.85%. Now, also, a lot of the people that are treated with insulin don't actually meet the targets set out by their clinicians. And there's a variety of different reasons as to why this potentially happens, but often there's something called psychological inertia. So what we tend to find is there's clinical inertia where people actually delay the initiation of that. Now, that's through a variety of different reasons. And some of those reasons relate to when people initiate insulin is that they often can gain weight. So what we actually know is that when people initiate insulin, there's a weight gain of anywhere between 3 and 9 kilos, generally in that first year. And anywhere between 50 and 60% of that is actually fat. So actually there's an inertia, there's actually clinicians, but also patients not necessarily wanting to go onto insulin. But there's other reasons as well. There's fears of low blood sugars or hypoglycemia, but also patients feeling like they've failed. Often they see insulin as the last resort. And when people are started on insulin, what tends to happen is there's an immense sense that actually I've failed to stick to the result, to your advice, and therefore I am a failure. But also there's other things like the injection and social stigma that links in with insulin. Now, obviously, it's important that we help people that are treated by insulin to manage their diabetes. And so part of the reason that we did this study was really to help people that have advanced type 2 diabetes that are treated on insulin actually get the care that they need.
Right. Okay. So could you then just briefly explain exactly what you did? It was a very similar design to the previous weight loss studies, wasn't it?
Yes, very much so. And I know that you've had Professor Tahiri and Professor Lean already talk about their DIADIM and the direct study. So what we actually found out, there was no randomized trial that actually examined using a formula low energy total diet replacement program in people concurrently treated with insulin who were living with type 2 diabetes. So what we did is we randomized or took 90 individuals with advanced type 2 diabetes treated with insulin to look at how effective using this low energy formula based diet. Now, Tony, would it be good to sort of describe what that low energy formula based diet is?
Well, I think that previously, but yes, essentially it's a formula based on soups and shakes. It provides all the energy that is needed to make it up to 850 calories and then also sufficient micronutrients to meet the daily requirement. So it's nutritionally complete, but obviously energy restricted. It's been used extensively. That was what was used by Mike Lean and by Sharad Tahiri in his studies. So it's the same diet essentially, but delivered to a different group of people who actually have other challenges in their management, don't they? Because, for example, medication management in this type of patient is a little bit more difficult as they're losing weight, isn't it?
Very much so. It's really very complicated. The whole process is a little bit more complicated related to what's needed. So what we did is we took 90 patients and we randomized them into one of two groups. They either were in this intervention group, which was the total diet replacement, which we did initially as 4 shakes or soups or bars a day, and that was, as you said, anywhere between 808 to 850 calories per day. We did that for 12 weeks. After 12 weeks, what we did is we did another 12 weeks of food reintroduction. So this is a really, really important stage. So what we did is we gradually reintroduce food, because often food can be one of those things that people are scared of. People, when we reintroduce, because often food can be seen as something that controls their life. And by removing the food, often being on these products, these total diet replacement products, we find that people regain control. So this food reintroduction phase is often the most important phase when we actually see it in these interventionals or these diets. And so we did 12 weeks. We did 6 weeks of 1,000 calories, and then we did another 6 weeks of 1,200. And then after that, for the remaining 6 months, what they did is they went on to an energy restricted diet with physical activity advice. And the other group got recommended into standard care. So the standard care was an energy restricted diet with physical activity advice. But in addition to that, what we did is we did behavior change as well. So they got behavioral advice on how to deal with emotional eating or self-monitoring that we know can help individuals, but also how to cope with sort of slip-ups and setbacks. Now, the only difference between the groups was actually the diet. So they got exactly the same care. So by the end of this study, what we could do is we could hopefully very convincingly say whether it was actually the diet or or not that actually made those changes.
And what were the differences between the two groups at the end in terms of the weight loss and the use of insulin and the dosage of insulin and so on?
Indeed. So there was a significant reduction in body weight. So what we found is that the intervention group, the total diet replacement group, lost around 9.8 kilos compared to around 5.6 in the other group. Now, this just shows that often people say that when people start on insulin, they really struggle to lose weight. But this sort of really shows that given the right support and the right advice, even on standard care, people can effectively lose weight. And that was highly significant. Now, the insulin doses were really impressive reductions. What we actually found is we found nearly 40% of people on the total diet replacement stopped their insulin at 12 months, compared to around 6% in the other group. So a real significant reduction in people actually stopping insulin. We saw doses reductions of around 75% within the intervention group, but also we saw improvements of things like quality of life as well, which is so important in this group that we know are impacted on by insulin, that actually significantly reduces their quality of life. So actually we saw around a 10-point improvement in our assessment of quality of life by the end. But one of the most important things is, you mentioned right at the start about the managing of patients, and particularly going on these diets, and the fear of low blood glucose, which is always the worry. Everyone's like, but isn't this going to cause more hypoglycemic episodes? But actually what we found was actually the group that were on the intervention actually had less hypos than the other group. Now, we racked our brains to try and figure out exactly what was going on there. But what we felt was actually happening was people struggle to know how much carbohydrate or starch is, or glucose or sugar is in their food. But when they have the products, it's very easy. They know they're having 120 grams a day, and they know how to therefore give themselves the right amount of insulin to manage their blood glucose.
So the position then is that publication appeared. Everybody's concentrating at the moment on helping people in the very early stages of type 2 diabetes achieve weight loss and so on. And I'm not aware of anybody who's very actively pursuing this question of, can we help people who are actually insulin treated? Do you know if anybody is currently working on this, or ideally, if you had adequate resources, what do you think should be done?
That's great, and it is such an important area. It's something that we did this study, and we published it back in 2019. And however, since then, it's not been picked up by NHS England. They focused very much on remission. They focused on prevention, as I said at the start. But actually, just recently, and we're really happy to say, is that I've just been involved in an Innovate grant with another provider, looking at using low energy diets, using digital management in this patient group, in addition to using a continuous glucose monitors as well. So hopefully what we're going to find is we're going to get some new data to hopefully complement what we've already done, and hopefully then we'll get a treatment that can actually help people living with type 2 diabetes treated on insulin.
Yeah. The other interesting thing in terms of the results here was that you used behavioural therapy, and actually the usual care group actually had extremely good results. In normal practice, if you took a group of people and put them through your usual care pathway, you'd be very pleased with the outcomes in that group, wouldn't you? Obviously, you got better in the formula diet treated group, but you'd still be pretty pleased with the responses in the usual care group, I'd have thought.
I think very much so. We saw a reduction in insulin. We saw an improvement, a reduction in HbA1c, although it wasn't significant. We saw a significant reduction in weight. So actually, we did some really great things. The issue that we often find is this patient group is often under-resourced. They are dealt with in primary care, and they're dealt with as well as they can do, but with limited resources that's needed to actually manage this highly complex group. And so what tends to happen is that often in a 10-minute consultation where GPs or primary care physicians will see their patients, what they do is, what do they do? Can they do behaviour change? Can they do all the things that I managed to do in our trial? Very limited. And what tends to happen is your HbA1c has gone up. So what do? We increase medication, as opposed to actually dealing with the issue there, which can often be related to someone's body weight or related to how they're managing their lifestyle at that present time, but also trying to help them to come up with goals and skills that can actually help them to make changes that would help them to reduce and improve their blood glucose.
Yeah. In practice, for the United Kingdom, how do you think we would best deliver this? Now, obviously, we're talking to listeners who are watching in a number of other countries around the world, but for the UK, how could we do this? I think GP hub, specialist hubs, for example.
I definitely think that we need specialist treatment, Tony, without a shadow of a doubt. I think they are currently rolling out the low calorie diet program. And I don't think there's going to be much alterations that need to happen to allow for such a program to happen within the UK. Now, in terms of the numbers of people, to help as many as we can, it seems sensible to have some sort of blended approach where we have some face-to-face and some digital, or completely digital, to allow larger rollout of this. But what we need to make sure that people are supported by their healthcare professionals, those who understand the diet and can give the sufficient advice. Because as you'll know, Tony, a lot of individuals that who came to see me for weight management advice will have done a low energy diet in the past, but often done it unsupported. So they come in and go, oh, it doesn't work. And the reason it doesn't work is because they haven't had that support. Yeah. And so that additional support is absolutely key within this whole process.
Do you have any clues about the health economic aspects of this type of intervention? Would there be a likelihood of actually saving costs to the healthcare provider? For example, there would probably also be some reduction of some other medications. So there might be some other savings as well as diabetes medications.
Yeah, very much so. Now, obviously, we didn't do that within our study. It's something that was missing. We're hoping to do it in this future study that we're coming through. A health economic assessment is absolutely key here. And so what we're seeing is significant reductions in insulin doses. As I said, nearly 40% of people came off insulin completely. And what we noticed is there was significant improvements in HbA1c, in blood pressure as well. And so what we would like to sort of understand is actually there'll be improvements in reduction of insulin. We actually stopped all GLP-1 and also SGLT2 inhibitors. So the majority of individuals were actually off medication. Off the majority of their medication by the end. So I do imagine that there would be significant reductions or improvements in health economics by the end, and cost savings from a reduction of medications, but also the patient as well, Tony. I think there's going to be significant benefits as well.
Okay. Very good. Thank you very much. So to conclude, of course, we need to give careful and cautious guidance to individuals, that people who are treated with insulin do need to seek guidance from their healthcare professional group before they embark on any major weight loss program of this type, because the medications do need to be guided. As always, in association with this video recording, there will be some web links underneath and some text to guide individuals who need further information. So Adrian, any final words now about exactly what we should say to such individuals in terms of what they can do? Some people can achieve weight loss by conventional diet, can't they?
I think the absolute key here is to go and speak to your healthcare professional. Go and get some support, go and get some advice from individuals to help you to make those changes. I would see if you can access these types of diets. They can be highly effective in helping you to reduce down your insulin, improve your blood glucose, and also improve potentially, hopefully, your quality of life as well through not having to inject insulin. But the first key is go and see your professional, get some support, and see if they can help support you to use such diets that can actually be effective in helping you to achieve your goals.
Great. Thank you very much. Thank you very much, Adrian Brown at University College London. It's been a pleasure talking to you, and maybe at some point in the future we'll have another conversation about related topics. So thank you very much indeed. Thank you.
Wonderful. Thank you.